Well, hello and welcome to the Disera Clinical Education Infectious Disease Podcast. I'm your host, Zachary Schwartz. In today's episode, we discuss the most recent studies on emerging treatment options for treatment-experienced people with HIV. We cover all kinds of topics, including the most recent Artistry 1 and 2 data on the investigational combination of biclen, data on doravirine and islatravir, specifically in people with multidrug-resistant HIV, and other studies in people with viremia who have challenges with their regimens. So let's, without further ado, get things started and turn things over to our faculty.
So, hello, I'm so excited to welcome our listeners to podcast number 3 entitled What's New? Simplifying the Complex, Exploring New Approaches in HIV Care for Treatment-Experienced People. My name is Charlotte-Paige Rolle. I'm an adult infectious disease physician and the Director of Research Operations at the Orlando Immunology Center in sunny downtown Orlando, Florida. And I'm super excited to be joined today by my esteemed colleague, Dr. Paul Sachs, who I will let introduce himself.
Oh, thanks so much, Dr. Roll. And we're going to go on first name basis from here on out. I'm going to force you. So my name is Dr. Paul Sachs. And again, you can call me Paul. And I'm the clinical director of the Division of ID at Brigham Women's and a professor at Harvard Medical School. And delighted to be here to discuss these very exciting advances in management of treatment-experienced patients. So I'm going to start you off by asking you, since I know you enrolled people in this study, I'm going to ask you to talk to us about the Artistry 1 studies.
Awesome. So thanks so much, Dr. Sachs. And you were right. I had fun in the Artistry clinical program. So, Artistry 1 was really an interesting study, a lot of excitement generated around this data at CROI. And for our listeners, this was a reminder, this was our open label trial that looked at switching to a combination of bictegravir and lenacapavir in people with HIV on what was considered complex antiretroviral regimens, right? And this study enrolled over 500 individuals and either randomized you to switch to the new combination of biclen or continue on your baseline regimen. Dr. Sachs, these folks couldn't have had resistance to any of the study drugs, and they had to have been stably suppressed on their regimen for at least 6 months. And really, the take home message from the data presented at CROI was at week 48, we saw non inferiority of bictegravir and lenacapavir compared to staying on a stable, complex regimen. We saw stable immune function through week 48. And overall, the study drug was well tolerated with few discontinuations due to adverse events. And so, again, I remember being in the room when this was presented, Dr. Sachs, and I was presenting in the same session, okay? But all the excitement was for Artistry 1. Chloe Orkin, she got so many questions about this data, Dr. Sachs. And out of curiosity, why do you think this generated such a buzz? It's just something
So,
that we've just all been waiting for such a long time?
well, I think there are a lot of providers who have people with HIV that are taking complex regimens. Often these regimens were arrived at years ago, so they involve boosted protease inhibitors, multiple different drug classes. And frankly, they also preceded the availability of high resistance barrier integrase inhibitors, dolutegravir and bictegravir. So I've always taken the view that those patients really, once we had the results of studies like 2SD and my colleague Serena Koenig and her study that she did in Haiti, once we had results of those studies showing that stable patients, even with prior NRTI resistance, could switch to bictegravir FTC TAF or dolutegravir tenofovir FTC or 3TC, I've always viewed those people on complex regimens as people who could switch previously, but a lot of them didn't switch. There's a reluctance to switch. But now we know from this study that there's another option, which is biclen. So I think that's important. I do want to point out something with this study, and this is true about almost all open label trials. If you look at the discontinuations for adverse events, it was really higher in the biclen than in the stable background regimen. And that is what's commonly referred to in clinical trialsville as ascertainment bias, because people who are on a stable regimen, when they switch, if they have any kind of side effects at all, they're going to blame it on their new regimen. So I don't really think these were severe adverse events. And we have proof of that with the Artistry 2 trial. And that's the one I'm going to discuss. I think this one didn't get nearly as much attention because it just compares the most commonly used oral regimen, bictegravir FTC TAF, to bictegravir lenacapavir. But this was a blinded study. And in this study, you get really important information about side effects. Yes, both regimens were really effective, but there was no difference in discontinuations due to adverse events, 2% in each arm. So I just want to bring Artistry 2 up as an important counterpart to Artistry 1. I want to mention one other thing about Artistry 2, and that is there was one patient in the BIC-Len arm who developed virologic failure with actually slight resistance to bictegravir. This is the most common mutation selected, but bictegravir, people who fail at first line or integrase first line is 263K, and that's what
Mhm.
emerged. I would suggest that possibly, this combination BIC-Len is best for people who are really good at taking their regimens, and that includes all those people on complex regimens like I was talking about, but might not have quite as high a resistance barrier as people who are taking bictegravir with nucleosides. What do you think?
I could not agree more, Dr. Sachs. As someone who's done a few open label switch studies, you are so on the money when you talked about that what we always see if we look at any really open label switch trial in our field, we always see that safety profile, especially early on in the trial, right, Dr. Sachs? And then
Yep.
it seems as time goes on and people get more used to their regimen or people just relax
Yeah.
about being in a study, we kind of see that difference in adverse events dissipate. I have certainly personally seen that in trials that I've conducted. So
Yeah.
thank you for mentioning that. One thing of note, Dr. Sachs, about Artistry 1, can you tell us a little bit about those lipid differences
Yeah.
that we saw
Sure. I mean,
between
people,
Biclen
yeah.
and the stable regimen?
Yeah, I mean, if people coming off boosted protease inhibitors or boosted anything are going to have improvements in lipids when they switch to Bic-Len. So that's a nice thing. And I have to say, let me give you a patient anecdote. There was someone who was a study participant who came up to me and he said, this study changed my life. Basically, I was taking gobs of pills and I was on, boosted PI and having diarrhea and my lipids were all out of whack. And I switched to this single pill and I couldn't be happier. And that's great. That's what this regimen's for.
Yeah, I could not be more excited for our patients who can really, really benefit from this, Dr. Sachs. So, speaking of single tablet regimens that have somewhat unique resistance profiles, I want to take the opportunity to segue us into a discussion of doravirine and islatravir. And I want to remind listeners specifically of the heavily treatment experienced protocol that enrolled multi-drug resistant patients. Now, some of you may remember there was a clinical hold on the initial dose of islatravir used in the DOR-ISIL program, and that was the 0.75 milligram dose. But prior to that clinical hold, protocol 019 was open for enrollment, and they actually did manage to enroll 35 patients who did continue in the study through week 48. And I'm not sure, this protocol, Dr. Sachs, was actually never really presented at a Congress per se, but the manuscript did come out in AIDS earlier this year. And we saw that of those 35 individuals enrolled, about 71% were suppressed at week 48. And I want to remind the audience this trial enrolled at the same time as the Capella study. My site, Dr. Sachs, had both studies, and the criteria were the same. Okay.
Huh.
So these were people multi drug resistant, previously failing a regimen, and unable to construct a suppressive regimen with currently commercially available antiretrovirals. We saw suppression rates of 71% at that month 12 time point with, generally, I will say, well tolerated, a safety profile of DOR-ISIL in the trial, about 9 folks having drug related adverse events. And so, I think DOR-ISIL, Dr. Sachs, it often gets kind of forgotten when we think about our heavily treatment experienced patients due to the premature stop of the study and the fact that it did not complete enrollment. But How do you think about this particular combination when it comes to the HTE population, especially considering we're about to have BIC-LEN available pretty soon, hopefully by the
Well,
end of this year, definitely.
I think the issue with islatravir is that, first of all, doravirine resistance is something we do see in clinical practice. And we see it in clinical practice in people who've had extensive NNRTI exposure. And so, there's this Y188L mutation, there's the 106 mutation. If you look at genotypes, you will not see 100% activity of doravirine in people with NNRTI mutations. Certainly, it's active against K103N and Y181C, but not 100% of patients with NNRTI resistance have just those mutations. In addition, there's a suggestion that the islatravir really is not a good drug for people who harbor the M184V or I mutation, which is selected by lamivudine and emtricitabine. And if that's the case, then I would say BIC-LEN is going to have a much greater utility in the highly treatment experienced population than doravirine islatravir.
I totally agree, Dr. Sachs. And I think that's the buzz on the streets from who I've talked to and asked that same question, but always great to have your perspective. Now, Dr. Sachs, in the recent years, we have seen some exciting clinical trial data from some of our long-acting regimens that
Mhm.
actually also hold promise for this population, given that they're not affected by many of the resistance mutations that we see prevalent in our HTE patients. Can you tell us a little bit about what's on the horizon for LEN, TAB, and ZAB?
Yeah, Len, Tab, and Zab. I got to tell you, I'm a bit of a, how do I put it, a bit of a skeptic when it comes to bNAbs for HIV therapy. And yet, when I look at the clinical trials that are going on with bNAbs, I must say this particular strategy, which is lenacapavir injectable every 6 months and two parenteral broadly neutralizing antibodies, terapavimab and zinlervimab, which are Tab and Zab, and we saw very good results in phase two. And as a result, because of those good results, these is every 6 month treatment. The thing I wanted to highlight is that a phase three fully powered clinical trial program is about to start. And that's very exciting. And it'll look at one population will be people taking just stable oral ART. And then it will randomize them to receive either lentabzab or our current long-acting injectable, which is caprilpivirine. So it's every 6 months versus every 2 months. But the every 2 month, of course, we have all this experience with, and the every 6 month is really investigational. That's one of the clinical trials. And the other clinical trial is for people on stable oral ART, randomized to continue that or to switch to every 6 month Len Tab Zab. So two different fully powered trials. I'm excited for them to get started. Just since you are such a productive clinical trial site, I assume you'll be participating in those studies.
Yes, Dr. Sachs, and might I even secretly tell you we already have a wait list
Oh,
building
awesome. Yeah,
for both of those studies
that's
because
excellent.
everyone's into long acting these days, right? And so as
And
soon as
every
we
six
get
months.
selected exactly for exciting protocols like this, we start immediately telling our patients about it. And so we have some wait list building, and we're very, very excited about that clinical program at our site. And so, just to round us out, Dr. Sachs, when I'm thinking about long acting, I think there was one trial that was presented at CROI. It was only a poster, but it really stood out to a lot of people. And that was the use of long acting cabrylpivirine in folks who are really being challenged by oral antiretrovirals, right? And so this was a small cohort, right? 45 participants from Taiwan, experienced folks who had viremia, okay, had viral loads of at least 200 copies, and they couldn't have had resistance to cabrylpivirine and either enrolled to immediately switch to long-acting cabrylpivirine or have a delayed switch in which they remained on their oral regimen until week 24, at which point they then got to switch to cabrylpivirine. And the study authors presented their week 24 primary endpoint And Dr. Sachs, it was very, in my opinion, impressive. Okay, we saw 88% of these individuals achieve viral loads less than 200 copies, and 76% achieve viral loads less than 50 copies. And again, these were folks that were challenged by their oral regimen, unable to achieve suppression. And when I think about HTE patients, certainly when I think about my own clinic population, a lot of my HTE patients, they're suppressed, Dr. Sachs,
Yeah, of
but
course.
they're on regimens that, like you commented, that anecdote you told us about, they're on regimens that they're kind of struggling with, right? Like they're so used to these side effects, they become a part of their life. These regimens are not optimized for them. Okay, it's just the best that we've got that we're giving them based on their resistance profile. So this data is kind of exciting. What was your take on the SUPLA trial?
Well, I thought every CROI, there's one research study that I feel should be given an oral presentation and gets put as a poster. And this year, this was my vote. Because remember, all of the studies we've heard about in cabrolpivirine or in lenacapavir for people with viremia, all those studies have been cohort studies. Now, they're really not done in a prospective way. They're really descriptions of real world evidence. There's something much stronger about a prospective study, in particular, a prospective study with randomization. And that's what this study had. And if you look at the population, it's people with true viremia. I mean, the median viral load at entry to the study was 35,000. These are people who'd been struggling to stay on oral ART for years and hadn't been able to do it. And all that, exclusion was that they had no resistance to cab or pivirine. So that's actually very important. And then two other things of note about this, in addition to the better virologic results that you mentioned, I asked the investigators, I said, did you have anyone fail with drug resistance? And they did not. They had one person who had virologic failure, but the person did not have drug resistance. So, even though we worry about drug resistance in cabrolpivirine, even in people who are suppressed at baseline, in this study, it was not that it wasn't observed. And I on a site now, one of the larger cohorts of people with viremia getting cabrolpivirine, and this is the combined cohorts of Emory and of UCSF, they have shown only a 6% virologic failure rate with resistance, which is incredibly, incredibly uncommon. So I think this is becoming the de facto best regimen for people with viremia because they can't take oral ART. And that's something that is not in the package label and something that's going to be addressed in the results of the CROWN study, which is fully enrolled, a larger study of cabrolpivirine for people with viremia. So very exciting results.
Absolutely, Dr. Sachs, and a really good follow-up to the Latitude study, right? Because I think
Yeah.
when we think about this particular population, folks that continue to have viremia and ongoing challenges with their oral regimen, this is the kind of approach that we take, an immediate switch to cabrolpivirine in really an effort to control someone's HIV and honestly change the trajectory of their health.
Yeah.
And so very, very excited to see the results of CROWN and SUPLA, definitely, even though small cohort, supporting that. And like you said, poster presentation, but a lot of us gathered around this poster because we were very excited for these results.
As the editor of an ID journal, I was extremely interested in recruiting that trial to our fine journal of clinical infectious diseases, and I have my fingers crossed that they'll submit it.
Thanks, Dr. Sachs. I think any invitation from you in that nature is one that it probably is going to receive a favorable response.
And speaking of Dr. Sachs and Dr. Roll, I said at the beginning we're going to go in first names, but you decided to ignore me. Anyway, that's what you've been ever since I interviewed you for residency. You've been someone who's called me Dr. Sachs, and that's fine. I have to just get used to it.
I'm so glad that you're totally okay with it, Dr. Sachs. It was probably never going to change. Just an FYI. We covered several important recent clinical developments for heavily treatment experienced patients, and really, Dr. Sachs, I think we're approaching a horizon and a new paradigm for this population where I think viremia is going to be unacceptable, right?
Yeah.
For these patients, and I would argue that that's actually the case right now. But I know for some of us, we are challenged by coming up with suppressive regimens for some patients in our practice, and we allow folks to kind of coast in this low level viremia state because their regimens are not optimized for them, right? And I
Mm.
think with all of the data we've discussed, we've just talked about some exciting oral options, we've talked about some long acting options. We're going to come to a place pretty soon where viremia is not going to be acceptable for anyone. And I think that that's incredibly exciting and gives me a lot of hope for the future for all of our patient populations.
Yeah, no, I completely agree. And it's very gratifying to see all of these different tools we have to really get the last group of people without virologic suppression, virologically suppressed, and to take the large group of people who are virologically suppressed and give them so many different treatment options, especially in the long-acting space. So allow me to just thank you for inviting me to join you on this podcast. It's been very exciting to see the very impressive career trajectory you've had since all those years ago when we first met.
Well, I had a great start, Dr. Sachs, which was sitting across from you, right? So, with that said, I definitely want to take a moment to thank our listeners. I hope you were as excited as Dr. Sachs and I were to review this data. And I certainly hope that you found this information useful for your clinical practice. Thank you so much.
Well, thank you to our faculty and thank you to you, our listeners, for joining in. To see more detail on all the studies mentioned in this podcast, click on the link in the show notes. And to get all of our latest podcasts, subscribe to the DESERA Clinical Education Infectious Disease channel on your favorite player. Thanks so much. We'll see you on the next podcast soon.